Preparation is the foundation for success in any endeavor. Now I'm talking about you being prepared when you see the doctor and you're told that you have an elevated PSA or that your biopsy came back positive and you have prostate cancer. In the next few minutes, I'm going to share with you some questions you should already have in your mind, things you need to ask. When you have an elevated PSA, an important question, very fundamental, do I need to see a urologist? It's not a requirement, it's an option. We'll explain why I am a little skeptical of the movement vigorously toward a urological consultation. Just because you have an elevated PSA does not mean that you need to go to a specialist. Your primary care doctor can manage this. However, you're going to need to be assertive. The primary care doctor is almost obliged to make the referral. It's a medical legal thing, right? It's a peer pressure thing. But if you say to him or her, I don't want to see the urologist, doc, can you manage this for me? That will liberate them to make that recommendation for you. How about this question? Do I need a biopsy? An elevated PSA, folks, is never a trigger to an automatic biopsy. You never need a biopsy. It is an option. We'll explain the limits of that. Well, let's talk about it right now. Biopsies have been around since the 1980s. Now just freeze frame for a minute. The 1980s. Folks, that was 50 years ago. The 1980s, we had gas lines. I was wearing bell bottoms. They were talking like ancient history. Do you mean to tell me that in 50 years, we're still jabbing needles in prostate glands? That's as good as it gets? How about an alternative to that? How about, can I just do an MRI of the prostate? The MRIs came into vogue in the 2012, 2015 era. Between MRIs and biometric monitoring, PSAs and others, we have the ability to assess the health of your prostate gland without a biopsy. For a lot of reasons, urologists are not enthusiastic about the non-biopsy approach. You'll have better luck working with your primary care doc if you empower them to do it in a manner that is not biopsy-centric. Here's another question, folks. So we talk about asking them, do you need to see a urologist? Asking them, can we monitor this without a biopsy, perhaps with an MRI? Suppose insurance doesn't pay for that MRI. This is ridiculous, but some insurance companies, they actually require a biopsy first. That's just stupid. Now, just because the insurance company is stupid doesn't mean you have to embrace their stupidity. The average cost for an MRI in the neighborhood of $800. You could probably negotiate it lower, get a cash discount. It's worth the money if it avoids a biopsy, which it can do. Here's another question, a little bit off the trail, but very relevant. What's my calcium score? A calcium score has nothing to do with your prostate. It has everything to do with your lifespan and death and your heart. What do most men die from who have prostate cancer? Answer, heart attacks. So before we start chasing the PSAs, before we start scrambling to look at Gleason scores, let's get a full spectrum view of health. A calcium score greater than 100 in a man over 60 correlates with an 18% 10-year risk of death from all causes, including heart disease. Whereas early stage prostate cancer, presuming it's there, has a 10-year mortality rate of about 1%. So we want to be able to risk assess. I hate to break the news to you folks, but nobody's getting out alive. Our goal is to extend life with the greatest vitality. There's nothing about getting a biopsy that enhances your health, right? It just scratches an itch. Another question to the doctor, the urologist or your primary care doc, when you have an elevated PSA, what lifestyle changes can make a difference? If this question stumps them, you need better consultative information because there are a host of lifestyle changes that can alter your risk profile for prostate disease, including cancer. So you want to know the answer to that question And if your doctor can't provide it, you want to find someone who can. Now, the internet can be very helpful, but don't lean heavily on it. You'll go crazy. There are about 1,000 different pathways, from apricot seeds to water fasting, that are absurd. So be warned. Use your intelligence, use your instincts. What role of MRI? We talked about that. Do I have to then acquire biopsies to monitor this condition? What interval of PSA testing would you recommend? And what would you expect my PSA to do over the next several years? These questions are worth asking so you can frame out a plan with your family doctor. I'm advocating for you to avoid urology consultations, at least at the early stages of evaluating this condition. Avoid them. However, if you choose to get one, be prepared. Be prepared with your own knowledge. Be prepared with your own resolve, because they are oftentimes quick to recommend biopsy. Now, should you do one? In my opinion, a biopsy is an antiquated intervention that causes harm and does not provide information of value that can't otherwise be acquired through non-invasive testing. In addition, based upon common sense and supported by research articles, it can cause metastatic spread if cancer is there. And finally, the biopsy is horribly inaccurate. The idea that you can somehow take an MRI, target a nodule, and stick a needle in it, and that is superior and more accurate, is absurd. It defies biology. When somebody has skin cancer, I like to draw these analogies. There's a procedure called a Mohs surgery, where they take little slices around the skin cancer and they look at it under the microscope. Why? Because they can't tell just by looking at it with a naked eye whether or not the cancer is present. Why? Because the cancer spreads in tentacles, and they have to look at each slice to find out where the edge is. So too with prostate cancer. You cannot target it with a needle. You cannot target it with radiation. That is a false hope. It has tentacles. So to the extent it's in the gland, we're going to let it sleep. Now, we talked about some questions if you have an elevated PSA. Suppose you already had a biopsy and you've been diagnosed with prostate cancer. What then? Well, there's some important questions to ask. Chief among them, can we monitor this cancer without further biopsies? The biopsy, if it's been performed, and if it shows prostate cancer, you have what you need to know. You have prostate cancer cells in the gland. These are what I call atypical dormant cells in most cases, ADCs. So long as they stay in the gland, they will never harm you. Now, they'll say, but we have to know if it's changing. Remember, folks, the biopsy is a 1980s technology. We have better methods. You can look at the MRI. If it's changing, the MRI is going to pick it up. If it's changing, the biomarkers are going to pick it up. You do not need to do biopsies. They're harmful. So just stop. Doctors like them. They get reimbursed. There's a lot of reinforcement psychologically, financially, and medical legally to doing these biopsies. The standard of care of doing sequential biopsies is simply not proven to protect you. It's just there because. It's there because. So there's that old saying in medicine, how do you convince a doctor that what he's doing is wrong and he should change his approach? Answer, you wait for the doctor to die. Doctors, once they adopt a pattern of care, are very slow to shift. They like what they do. Ask the doctor, which biomarker are you going to use and why? There are a host of them out there. None of them are distinctly superior. They all have their pros and cons. In my opinion, you want to have consistency so you can compare apples to apples. Whatever biomarker your doctor is using should be tracked periodically so that you can see any variances that are relevant. You want to know the calcium score. Now, your urologist probably doesn't know much about a calcium score. In fact, most doctors don't know much about it. For those of you that are curious, you can find my paper. Go to PubMed, Dr. Petteruti calcium score. The research that we have done on this shows an ability to reverse it. But more importantly, for your purposes, it puts risk in perspective. Am I a heart disease guy? How much lifespan do I have? Where should I put the focus of my energy? My dad was a family doc, and he used to say, if you're destined to die by the knife, you don't fear the gun. Look, none of us want to die. We all want vitality. Let's put the vitality first and foremost and not subject you to traumatic treatments. Another question for your urologist. We talked about the MRI, about the calcium score, about the biomarkers. Can we test for circulating tumor cells, CTCs? This technology is breathtakingly new, and it has merit. There's a test called the Galleri, which is put out by a company called Grail. They're one of others. It's not perfect. It's a blood test. It can pick up cancer cells, not tumors, floating around in your blood. Well, guess what, folks? If it picks up cancer cells in the blood, that is objective evidence that the cancer has left the gland, which means that to the extent any surgery, any radiation ever had any sense, and that's a highly dubious statement, it is now totally evaporated. You never screw with local treatment when you have cells floating around the body. Now, that test is not perfect. Early stage prostate cancer, it's frequently negative. But it has some value if your surgeons are contemplating radiation or surgery before they touch your prostate gland. In my view, this test should be done. The other test you should absolutely consider getting before anything aggressive, any of these conventional treatments that are sometimes advocated for you, can I get a PSMA PET scan, prostate-specific membrane antigen PET scan, that will target prostate cancer outside of the gland, and it can help you determine if there's disease beyond the gland itself. If there is, you're in a different category of treatment, eliminating radiation and surgery completely. Not that I ever advocate it, but even conventional doctors would have a tough time justifying such an intervention if the cancer has left the gland. You're in a different category. Find this out before they screw with your prostate. All right, so we talked about that. Here's a question. Now, this question may be a little bit uncomfortable for the doc, but it's worth asking. Doctor, do you own an interest in the Da Vinci Surgical Center that you are contemplating referring me to? It is legal for doctors to make profit from and own an interest in surgery centers of that type. It's not to say that it is patently unethical, but holy cow, there's a bit of an incentive there that you have a right to know about. Here's another question, equally uncomfortable and equally worth asking. Doctor, in the past year, have you received any financial consideration from pharmaceutical companies in regard to prostate cancer treatment? Yikes. A study from 2021 revealed that 87% of urologists received some form of compensation from pharmaceutical companies on the average amount of $650. Now, that is not a stop-the-press dollar amount. However, we know why the companies buy doctors free lunch. It's not because doctors would otherwise go hungry. It's because of the psychological effect of reciprocity. 87%. Now, that's an average amount. The money comes in several forms. It can be a speaker fee. Doctor, we're going to give you $1,000 to go to this restaurant and talk to your colleagues about whatever. It can be in the form of free lunches. It could be in the form of some nominal fee or consideration for clinical research. It's not to imply that the urologists are unethical. In my opinion, medicine doctors in general are highly ethical people. But they're people. They're influenced by things. You want to know where those influences lie. That's my only point. In a perfect world, you want your family doctor to lead the charge. But folks, your family doctor has been knee-buckled They have had their power taken from them in large measure. You can restore it by virtue of empowering your doc to lead the charge. Doctor, I want you to monitor my prostate. I understand that you're recommending the urology referral. Perhaps I'll go to talk to them, right? That's fair, that's reasonable. But be prepared to resist the urgency. If they look at you and say, you have to get a biopsy, time out. You don't have to get a biopsy. They should talk to you about the risks. A question you should ask. Could a biopsy potentially spread cancer? If they say, well, that's a good question. It hasn't been fully studied, but theoretically, that possibility does exist. If they answer like that, that's a rational answer. If they say, no, that didn't happen, that can't happen, that is comforting you in the face of illogical conclusions that are not research supported. So be prepared. Even write this stuff down. Remember, you're going into an environment where you are historically disadvantaged. The doctors have a lot of power. They have a lot of knowledge. In some cases, they have rather vigorous opinions. This is no time for you to be meek. This is your body. It's your life. It's your prostate gland. It's your erection. It's your urinary control. It's your muscle. It's your masculinity. It's your quality of life. It's yours. Own it. Do the research. Take your time. If nothing else, this is never an emergency. When you hear the big C word, I'm sorry, sir, your biopsy came back positive for cancer. The first thing you do, take a deep breath, go on a vacation, go to Aruba, hang out. There's no emergency. This is a slow-moving train. And by all means, continue to watch my podcast. Well, that's all I got for now, folks. I hope this information is helpful. I hope you share it with others. It's our mission to get information out, to educate men and the people who love them, so that you can have a balanced view of this most compelling issue that is really critical to your quality of life throughout the span. I'll talk to you next time. Bye.